I want to thank everyone for joining us tonight. We are really looking forward to sharing this information because we just think it is just so important. But let me introduce myself. I am Dr. Susan Rogers, and I am the immediate past president of PNHP. I'm a retired internist here in Chicago. The webinar is being recorded, just so everyone knows, and you will be able to get the recording on the Protect Medicare website in about a week. If you would like to listen again or share with your friends. So like I said, you've been introducing yourself on the chat. And so let me just get a little introduction about what we're talking about here. PNHP has been involved in the fight against the direct contract entities, now called the ACO REACH program. And we went to DC back in November of 21 after learning about this. And for over a year now, we've been diligently working to try to end this program. It is now the ACO REACH program, and REACH stands for Realizing Equity and Community Health, which makes it sound like something really good that we should be supporting, but we can't go by the name here. And we have also been meeting with legislators and been trying to push them to remove the bad actors and end this program. Now, unfortunately, as of January 1st, the REACH program became active and started running. And we've made some positive strides, but our work is just now beginning, and we really have to be very aggressive and advocate for what we're doing. We need to remain united in our organizing and advocacy to remove these bad actors. We need to make sure that everyone is ready to fight back against the corporate takeover of traditional medicine. And finally, we know that we cannot do what needs to be done alone. We need to build deep alignments with others toward a movement powerful enough to remove these bad actors and totally end the REACH program. That is why we will invest deeply in relationships with allied organizations, and why you are such an important part of what we do at PNHP. So to remove the bad actors and end the REACH program, we must all build a larger and deeper base of members. We need to build our base at a massive scale. Now we have to work together to build our membership base so we can take action together to remove these bad actors, end the REACH program, and ultimately win single payer for all. Every person you recruit, every petition you sign, every action you participate will help us build our movement. And again, the webinar is being recorded, and like I said, we will post it on the webinar next week. I would like now to introduce Dr. Ed Weisbart. Dr. Weisbart is a national board member of Physicians for a National Health Program, and he also chairs the Missouri chapter of PNHP. Dr. Weisbart, you have the floor.
Well, thank you, Dr. Rogers. So what a treat to see y'all, or if I could see y'all. We have much to talk about. This is an incredibly important part of our strategy going forward. So no surprise to anyone, I want to show you some slides, which I believe you can see now. So our topic, as you heard from Dr. Rogers, is to talk about the ACO REACH program, the ways in which it's being profiteered, and what it means for Medicare, and how this impacts our fight for Medicare for all. So I want to get a little bit wonky for just a moment. My only wonky slide, I promise you, I think. And that's just sort of a broader context of where we are in the United States versus the rest of the world. So each of these lines on this chart is a different country. Each one is a separate country. So if you follow any one of those lines, you're following them across a 50-year period. Take the blue one or the brown one, take any one of those. And you'll see in the bottom left-hand corner, these are 30 high-income countries. And at the bottom left-hand corner, you'll see that their life expectancy was maybe 73 or so, and with a national healthcare expenditure per person in US dollars, as you can see, much more modest compared to where it is today. And if you follow those curves along to the upper right, you'll see that by 50 years later, The life expectancies pre-pandemic have had pretty much all gone up considerably, as had health expenditures. And you'll see that most of the countries are sort of clustered together. If you're trying to guess which one of those countries is the United States, oh, let me give credit to Charlie Swanson, a physician who created this from using World Bank data. So thank you for extracting the data. So you'll see that the United States is hard to find on those lines because we're not on those lines. There we are. Interestingly to note, I think, is that back at the bottom left there, at some point around 1970, we were in the middle of the pack for all these countries. We were a little bit off center, but we were pretty close to the pack. But since 1970, we've migrated very little up in the way of life expectancy, but quite a bit up in terms of what we spend. So we are now quite the outlier compared to other countries. What's different between us and these other countries? Well, all of those countries on the left there have some form of national health insurance. They all have a different name for it. It's all quite different in every country, but some form of national health insurance. Whereas the United States, as you know, we don't have anything, really of that sort. It's not that we haven't tried. We've tried a whole bunch of different things since 1970. I would argue that each and every one of those it relies upon putting some sort of financial intermediary between the government or whatever the paying community is and Americans. The other countries don't do it like this at all. So I would argue that it's actually a straight line connecting the HMO Act in the early 70s to the core strategy of what we're still hearing about today and why we're meeting tonight. So tonight we're going to talk a bit about ACO REACH, and to get to that, of course, we need to understand what Medicare is, and frankly, we'll talk a little bit about Medicare Advantage as well. So Medicare, the red, white, and blue Medicare card that I hold on to with my life and death. We talk about traditional Medicare or original Medicare. Those are both synonyms if you're confused, and they both refer to what was created in 1965 as Medicare Parts A and B. So if you hear somebody saying traditional Medicare or original Medicare, they're talking about specifically Medicare Parts A and B. And so it's almost as simple as this cartoon looks. It's really not, as anybody practicing can tell you, there's more complexity than what I'm drawing. But in the simplest of cartoons, it really is this, where we pay our taxes, we get our Medicare card, and then Medicare directly pays physicians and hospitals on our behalf. And that's traditional Medicare. Medicare Advantage, Medicare Part C, is profoundly different from that, as is ACO REACH. So Medicare Advantage interposes insurance companies between Medicare and physicians and hospitals. So right off the top, you can see more complexity. Medicare has to have a contract with each of those insurance companies, each of which has a contract with every doctor and every hospital that's in network. So it's far more complicated, and it's more complicated than that, of course, because the insurance companies tell you which doctors and hospitals you can and can't go to in many cases. So it's much more complicated and frankly much less efficient. And as a result, Medicare Advantage is diverting funds from the public funds that are supposed to pay for Medicare. So traditional Medicare, Parts A and B, spends literally 98% of every dollar they've given in revenue on healthcare, directly on patient care. Medicare Advantage, that number ranges from about 12 to about 20%, and generally of overhead and profit. And so generally they spend dramatically more on administration, overhead, and profit than traditional Medicare. So right off the top, you can see that there's a much greater expense at operating Medicare Advantage. Despite that overhead issue, Medicare Advantage is continuing to grow, so that current data has them very close to 50% of the Medicare book of business. And that's frankly where we've been focusing on, watching that growth of Medicare Advantage for quite a while, because there's so many things that we're unhappy about Medicare Advantage and don't see a way to actually even save that program. So we've been focused on Medicare Advantage as the thing that we're not in favor of. But frankly, traditional Medicare is still bigger than Medicare Advantage. And the investment community has been recognizing for a few years that actually traditional Medicare is an opportunity into which they've had zero access. And it's that lack of access for the investment community in our minds that created, that drove the Trump administration to create the direct contracting system now called ACO REACH. There are perhaps a variety of other reasons that you could list too, but the most blatant one in my mind is that the investment community wanted a way to get into the traditional Medicare system. So here it is today. Traditional Medicare is roughly half of Medicare, and Medicare Advantage is perhaps the other half of Medicare today. And here it is tomorrow. This new program called ACO REACH, it used to be called Direct Contracting or DCE. This new program, ACO REACH, is on track to capture all of the traditional Medicare members. So the way it's set up within Medicare is introducing new middlemen, which the ACO REACH program, they're called REACH ACOs. So they're introducing new middlemen where they've never been before into traditional Medicare. Medicare is literally assigning Medicare members to whatever REACH ACO their primary care physician may have signed a contract with. So they're not telling you, they're not asking you, but they are assigning people to a REACH ACO. And then Medicare then prepays that REACH ACO for a range of services that is specifically negotiated and agreed to between the REACH ACO and Medicare, the Centers for Medicare. So Medicare prepays them, which means that the less services patients get, the less healthcare you actually get if you're in one of these outfits, the more money the REACH ACO can retain as profit and overhead, and it doesn't have to go to actual healthcare. So if you're not happy about that, if you find that things are if you don't like the model, which we're describing to you, or you find that being in one of these things is creating constraints that you're not happy about, we asked Medicare what you can do about that, and they said, no problem. If you're assigned to one of these, you can get out. You just have to find a new primary care doctor. That's kind of insulting. So this is all happening without Congress's oversight. Congress does not have to approve it. They're able to completely transform all of Medicare without Congress knowing about it. The latest data shows that there's one of these in virtually every state. It's predicted now that there's going to be more than 2 million people from traditional Medicare assigned to one, and Medicare has very clearly said their plan is to have literally everybody in one of these by the year 2030 or something like one of these. If you like these slides, you can have them. They'll be up on the PNHP website. So we've seen this a moment ago that that Medicare Advantage has, on average, perhaps a 15% overhead. The ACO REACH middlemen, if they can take their prepayment and not spend it on healthcare, they get to retain that, and they can actually retain the first 25% of what they don't spend on healthcare. They get to keep for themselves. The first 25% they can keep for profit and overhead, and if they cut healthcare services by more than that, they can actually keep an even higher percentage. But they keep the first penny of the first 25% that they don't spend of the money that Medicare was providing them with. So we think that that exposes the fundamental flaw that's plaguing many systems in the world right now, and certainly in healthcare in the United States, which is privatization. And within Medicare, this idea of introducing middlemen essentially breaks the promise that we have reasonably come to expect from Medicare. Medicare promised that doctors and patients would be in control of our healthcare decisions, and ACO REACH for the first time puts investors into that process. That's brand new. This introduces a conflict of interest, which is also brand new to traditional Medicare. Whereas I said, the more money they don't spend, the more money they can keep. The less money they spend, the more money they can keep. And this core model attracts what we've been starting to call bad actors. It turns out that most of the large players in this system, or their parents or affiliate organizations, have been either accused or investigated or settled claims or been sanctioned for fraud and abuse. And we call that bad actors. There are, to be clear, probably some good players within this system, but they're hard to find, and they're basically guppies swimming amongst the sharks. The system, ACO REACH, attracts and feeds these sharks. So let's talk a bit about bad actors and what we think we should do with this. So First, these accusations are very common of fraud and malfeasance. They're coming from really credible sources. They're not somebody just searching around and they come from largely from the Department of Justice, states attorneys general. Oh, I said that wrong up there, and various other, pretty credible sources. And they're often wind up creating this not plausible deniability, but implausible deniability. These accusations and such seldom come to trial or convictions. So they may settle for tens or hundreds of millions of dollars, but say, but we're just settling because we don't want to go to court. So we're not admitting any guilt. I call that implausible deniability, where they settle without admitting guilt. It turns out the more we look for these kinds of problems, the more we find, and the pattern that's overwhelming to us is that ACO REACH is attracting and rewarding fraud and malfeasance. And it's common. Here's just a few of the ones that we've been focused on that are in a report we're going to send you shortly. There's two that we want to focus on tonight, just for time. The people in this webinar will get a copy of the report emailed to them, and it'll also be posted at Medicare.net probably next week, along with the video recording and the slides. So here's one we wanted to talk about, Clover, and I took this today. Today from Clover's website. They're one of the DCEs and now ACO REACHes, and their website claims that they deliver healthcare 41% more cheaply than original Medicare, that they do this for 41% less than Medicare would cost. Oh my gosh, how is that possible? And they do that with broad and open networks. That's frankly almost too good to be true. And this, remind you, this is today, literally today, the day of this recording, on their website. Turns out that that's probably not actually something they can do very well. They've been fined by CMS. CMS is the Centers for Medicare and Medicaid Services. So you'll hear me interchangeably say CMS or Medicare, but CMS is the Centers for Medicare and Medicaid Services. And they've been fined for inaccurate advertising and marketing, perhaps of the type I just showed you. The Department of Justice has investigated them more than a dozen times in the last couple of years, and the SEC is investigating them for failure to disclose the DOJ investigations to their shareholders. So there's bad acting all over the place with this. And indeed, CMS determined that Clover misled or confused enrollees about their ability to receive care, in particular the network piece, and they failed to correct those statements after being told such by CMS. A former employee of Clover said that the small size of the fines, and they're complicated, so I can't give you a dollar amount of the fines, but the small size of the fines, frankly, emboldened Clover to view this as the cost of doing business. Why would you let a company like that have a chance to take over more and more of traditional Medicare? Why would you do that? Centene, near and dear to St. Louis, but national, of course, overcharged the VA by nearly $100 million a year and a half ago, was settled. And many overcharged many states. Again, so Centene, why would you want a company like that being able to get an even stronger foothold in traditional Medicare? So we believe we need to protect Medicare from these bad actors of this sort and from the bad programs. And that means first we need to, of course, realize that the goal that we all want, the reason our organization exists, and the reason many of you are in it, is because we believe the best way out of this whole mess is to fix the structure and get us to an improved Medicare for all system. Not today's Medicare, but improved. There are many things about Medicare that need to be improved, but that's still the foundation for a good system if we can hold on to it. And that means that we need to protect Medicare itself. We need to stop the privatization of Medicare that's corrupting it. We need to stop the profiteering within Medicare. And it's not just Medicare, bear in mind, it's Medicaid and probably a variety of other health services in the United States that we need to protect. ACO REACH really only focuses on Medicare right now. That means we want to stop the privateering. We want to end ACO REACH as a program. We think it's a faulty fundamental design. And of course, we have been saying for quite a while that Medicare Advantage is the poster child for that. And one of the strategies to accomplish this is to get the bad actors, the kinds of organizations I was talking about, get them out of this program. The program's a pilot program. CMS, from our understanding, is empowered to do that if they chose to. And we think if you get out the bad actors, that's going to go a long way towards making the system, frankly, unattractive to the investment community, and that it would be one of the pieces of ending ACO REACH. So we want to certainly get rid of those bad actors from the program, but really we call for the full ending of this flawed model and protect improved Medicare. So as we've said a couple of times, the link to this recording, to these slides will all be emailed to you. And there's a robust wealth of more information at protectmedicare.net. And back to Susan.
Thank you so much, Dr. Weisbart. As usual, an excellent presentation with a lot of information there. I hope everybody does at some point, if not after the talk today, but later this week, to go to protectmedicare.net, and you can get more information that's already on the website, and more will be added, including the slides and the recording, since this is being recorded, will be on that site. We are now going to just launch a poll and get an idea what people are thinking about how you all get your healthcare coverage, and if you're covered from any of these bad actors. So there is a poll up that I encourage everybody to respond to. And just to reemphasize what Dr. Weisbart has said, that what we are trying to do, what our goal is to remove the bad actors from these programs, to end the REACH program, and to stop the corporate takeover of all healthcare in this country, not just with traditional Medicare, but also with Medicaid. So this is really a healthcare justice fight. So after everyone fills out the poll, Matt will be able to post the results of that on the screen. Here we are. So we can say that a lot of people aren't in the two worst that Dr. Weisbart talked about, but a lot of people on this call are in programs that do not prioritize their health. They're in the programs that are prioritizing profit for their shareholders and for them, rather than prioritizing the health of the people that join those programs. So you can see that we really do have to really get together and work with our allies and work all together to go against these bad actors and this ACO REACH program. And so let's move on to our next speaker, and we will now hear from Dr. Diljeet Singh, who is on the call with us tonight. And Dr. Singh is a longtime women's health advocate. She is currently in the DC area, and she's an integrative gynecologic oncologist. And she is currently the Vice President of Physicians for National Health Program. Welcome, Dr. Singh.
Thank you, Dr. Rogers. And thank you to you guys all for being on this evening and being interested and engaging with us about this. I had wanted to talk, just give you guys a quick patient story. I recently changed jobs, although I've been a gynecologic oncologist for 20 something years now. This patient story I'm going to relay is unfortunately really common. The thing that's remarkable to me as a gynecologic oncologist, where a lot of my patients have had Medicare for a long time. And then before I came to this role, I'd been at Kaiser Permanente for about 10 years, and I hadn't been interacting much with people who had Medicare Advantage. Although Kaiser was a Medicare Advantage plan, I didn't see the denial, et cetera, side of it. Regardless, this patient of mine really didn't have healthcare insurance for most of her working life. She worked a lot. She worked 40 to 60 hours a week in different part-time jobs for many years. And she never really had a primary care physician. And she hadn't seen a gynecologist since she gave birth to her son over 40 years ago. And so she was really excited when she turned 65, and she got all these wonderful welcome letters and informational packets and, invitations to do this and that. And she ended up signing up for a Medicare Advantage plan. And, she wasn't really in the habit of participating in preventive care. And so she really didn't use her health care until she turned 67. And she had developed vaginal bleeding after no bleeding for 17 years. And since she didn't have a doctor and sort of had never really gone to one regularly, she went to the ER to be evaluated. In the ER, they told her she had mild anemia and she had an ultrasound of her pelvis and her uterus, and it showed an abnormally thickened endometrium. The endometrium is the lining of the uterus, and in people who've gone through menopause, it's usually less than a half centimeter. And she isn't exactly sure, but I saw the ultrasound report. And at that time, it was about 1.5 centimeters. So she was told to see a GYN, was given several names, and she saw the first available doctor who was on her plan 3 months later. I don't have the notes from that visit, as that doctor closed her office about 1.5 years ago. But the patient relayed that she was recommended to have a D&C, an outpatient procedure, looking at the lining of the uterus, and that they would sample that thickened area. And so she said, okay, well, I'll do that if that's what you think I need to do. And she didn't really hear anything from the doctor. And then she got a letter from her insurance company saying the procedure was being denied. So she reached out to the doctor and got a hold of a nurse, she said, and the nurse said, you definitely need this biopsy. But, with COVID, we lost our staff person who used to help people with these phone calls. And so you need to reach out to your insurance company. And my patient said the nurse gave her a code, a secret code that would help them understand. I assume this was a diagnosis code. Again, I don't know. And I don't know exactly what happened on the calls that she had with the insurance company, but she gleaned that she did not really need the procedure, that there was no documentation, she said, that she needed it. And, they'd been kind of mailing her things every couple of months, and they'd been in touch, and at some level she trusted them. And the bleeding had kind of decreased. And so she sort of left it at that. Guess I don't really need it because I don't, have the whatever they think I need. So 2 years went by and the bleeding got heavier, and she started to have bleeding daily. And so she headed back to the ER. And now she had pretty bad anemia. So she got 2 units of blood and was told her ultrasound looked worse. And to see a GYN, the only letter or follow-up she'd ever had from her GYN was a letter telling her that she was closing her practice, and recommending a list of other doctors, and she didn't have that letter anymore. But the ER docs gave her a list of people, and she couldn't find anyone on her plan who was taking new patients. So she wasn't sure what to do, so she went back to the ER and they decided that they would just refer her directly to me, a gynecologic oncologist, for a couple of reasons. One of them is we are the only gyn-onc practice in the area, and we do take uninsured and all insurances regardless. So she came to me and she got a biopsy, and not unexpectedly, her biopsy shows invasive cancer. I can't tell you guys more of the story yet. She's signed up for surgery next month. But what I can say is it's highly possible that, 2 years ago, she had precancer. It's highly likely if she'd had surgery then, she would never have needed a blood transfusion. And we know there's risks associated with that. And one of the things that kind of bothered me the most about this conversation and, talking to her about this was she is not upset in any way with her Medicare Advantage plan, and she does not blame them. She said she gets mailers from them all the time. They reach out a lot. When she tried to call, she was on hold for a long time, but she did end up talking to someone, and she's mad at her doctor for not following up with her. And, the fact that the only thing she ever heard from her doctor was that she was closing her practice. And this patient obviously, is not on ACO REACH. She's on a Medicare Advantage plan. And I tell the story in the context of this webinar because we understand what happens when people are being cared for by for-profit organizations, right? This story is extremely common for people under the age of 65. And I've heard that one many, many times, and I could give you stories about those patients also. But I think the piece that's so different to me in a way is I've never had a patient before who told me she trusted her health insurance plan, because that was the one she actually felt connected to. And she has, not been seeing doctors and didn't really have access for years, and then found that doctors didn't have availability. And there is a primary care physician shortage in this part of the country. I'm in the Virginia Beach, Norfolk area. And so she doesn't have any relationship except for this insurance company. And so now she trusts them. So that's the story. I appreciate y'all being on the call, and I'm going to turn things back over to Dr. Rogers to move on to the next speakers. And I'm happy to answer questions and, engage individually, however works, or however you guys have questions.
Thank you, Dr. Singh. I've heard that story from you before, but just hearing it again, it's just so disturbing to me. And I know that variations of that same story get repeated every single day in every city, in every hospital, in every clinic throughout this country. And so your story is really an example of what has become almost normal. It's not describing an exception. And I hope that what everybody can take from this is how important it is that we defeat this privatization of Medicare and the privatization of all healthcare that is going on in this country. There can't be a conflict of interest or some question about what your priority is. Is it the shareholders or is it the patient? And as a physician, I went to medical school and I trained so that the patient could be be my priority. So Matt is going to put up another poll that I hope everybody will take a look at and fill out. So, one of the things too that we can take from that story too is one of the mantras that PNHP always says is we say everybody in, nobody out, meaning everyone is covered. With a single payer program, everyone is covered. And so there isn't a question of whether you're entitled to get this service or you're entitled to get that, or no, you can't get this or whatever. And it also makes it clear about who's responsible for your care, not an insurance company hundreds of miles away in an office that you'll never see, but the doctor that you look at in the eyes who tells you what you're going to need. And it's interesting too, how, as Dr. Singh said, how the patient trusted her insurance company. And, marketing is a science. They know exactly what they're saying and how to say it to get people to believe them, for people to be comfortable with them. And that's another thing that we as physicians need to do. And all of us in healthcare, no matter what our role is or what particular thing that we do, the patients have to trust us. So do we have any results yet? Okay. It's a lot of results here. So everybody has had an issue. I had an issue with my insurance company about not covering something, and it took almost a year. So that you don't have to be deathly ill. You don't have to necessarily have complicated medical problems. You don't necessarily have to need an expensive procedure or long procedure. There's a lot of things that the system impacts on the people who live here and need to get their health care from here. So you can see that, you know, what is the biggest one? 60% of people, their prescription is not covered. And even now with Medicare, they're talking about trying to get a cap on 20 drugs. I mean, there's a million drugs out there, but they're talking about a cap on only 20. So the people who are out there to make money are not really in making decisions based on our best interests. Okay, so I think we can close that. And I want to go back and just kind of recap too, some of what we have done over the last, since we went down to Washington, DC in November of 2021 and presented a petition to Becerra, who was in charge of HHS. And in this petition, it was signed by many, many physicians, many organizations. I think there were over 10,000 signatures on that. And what we saw were the problems. So we need to get more people involved. We need to highlight this problem. We need to make sure that people understand. And this isn't just other physicians that you may know or other people in healthcare, you know, it's your family, it's your friends, because we all are going to need healthcare. And so we all need to do to know what we're doing so that we can make the right decisions. So one of the things in early December, Senator Elizabeth Warren and Representative, excuse me, Pramila Jayapal, they sent a letter calling for the expulsion of companies from the REACH program that have a history of gaming the public health programs. And it was signed by 21 members of Congress, including some committee chairs, caucus leaders, prominent Medicare for All champions. And PNHP research played a crucial role in identifying that these compromised companies as healthcare profiteers. That was their reason they were in healthcare, to make a profit. It was just a new way to make money, regardless of who lost in the process of them making money. Now, at the heart of organizing is investing in deep relationships with each other and our elected officials. And these take time. We all know that developing relationships take time. They don't happen over a single lunch, for example. But we're not going to get anywhere until our political leaders hear from us, hear from their constituents, which are us. And meetings with our elected officials are opportunities for us to get grounded in what we want and what we should expect from our representatives. We should be meeting with our elected officials to share our stories, to share the research that PNHP has done on the bad actors and the harm of privatization, and demand that they protect seniors, that demand that they protect people with disabilities, and demand that they protect the taxpayers' money from the bad actors by removing those bad actors from the landscape and ending the REACH program. So that is the world that we want to live in, a world with no bad actors, with no REACH program, but with universal, comprehensive, single-payer national health insurance. And it's important that our elected officials hear from us so that we can let them know that their decision-making on the real needs of their constituents is what they should be about. And when they don't act to meet our needs, they have to know that we will hold them accountable. That's our responsibility as activists. And at the end of the day, we put these people in office and they should be accountable to us. So if they want to speak for us, they should be willing to be ready to make time for us and to strategize. So we're going to put the link up to the Medicare.net link. And this, like I said before, this webinar is being recorded, and we will email the link to the webinar to everybody who was on the call tonight, and that's protectmedicare.net. And like I say, the video will be on the website next week. So I would now like to turn the stage over to Morgan Moore. Morgan is the executive director of the New York Metro PNHP chapter, and she has been instrumental to the growth of this chapter in recent years. When the COVID-19 pandemic hit, she played a major role in transitioning chapter activities online and continuing the series of high-quality monthly educational forums at PNHP New York Metro. Morgan, the floor is yours.
All right, thank you so much, Dr. Rogers. And good evening, everyone. I'm really glad to be joining you all tonight. And I hope that the information that you've heard tonight so far has inspired you to get ready to take action. I'll be talking with you now about a couple of ways that we can all take action together. And I'd like to start by explaining a little bit about why taking action is so important. I first came to this work as a volunteer community organizer, and for many years, and for many reasons, this work is very personal to me, just as I'm sure it is to the vast majority of you on the call tonight. 2 years ago, a dear friend and brilliant community organizer and health justice colleague here in Brooklyn named Ellen Belofsky was diagnosed with a highly aggressive, inoperable brain cancer. And in the last few months of her life, when Ellen and her husband, Dave, should have been spending her remaining time with friends and family, they instead were drawn into a protracted fight with her Medicare Advantage plan as they repeatedly denied her necessary and doctor-prescribed care. Bearing witness to Ellen's struggle for the dignified care that she needed and deserved has only strengthened my resolve to bring an end to these disastrous REACH and Medicare Advantage privatization schemes, and to continue to organize for single-payer Medicare for All and the New York Health Act in order to end the entire greed incentivized healthcare system that prioritizes profits over our loved ones and allows these bad actors to take advantage of people when they're at their most vulnerable. So what better way to channel our frustration and our rage than taking action against these bad actors? This evening, we're asking you to help us put a face to the countless people being harmed by these attacks on traditional public Medicare by contributing your photo to our photo petition. Seeing the people behind the statistics, sharing our personal experiences and connections can be an incredibly powerful motivator in compelling new people, especially our elected officials, to join us in this fight. So in the email invitation for tonight's forum, there was a link to our photo petition, which looks like this. Hold that up for you to see. And hopefully you found that link and you were able to print out your petition, your sign in advance. But if not, no worries. We'll be dropping the links to our customized photo petition signs in the chat now. Please select the one that speaks to you and go ahead and download it so that you can print it out. If you can't print one right now, no problem. You can also just follow along with me and submit your photo later. If you don't have access to a printer, you can also feel free to grab a sheet of paper and a chunky marker and really just write out your own sign instead. As a reminder, if you need to review any of the steps that I go over in the next few minutes, the webinar is being recorded and we will be emailing out the recording to all participants. And the webinar will also be available on the protectmedicare.net website next week. Okay, so once you have your sign printed, if you have your sign printed, I hope you'll do it along with me now. So we'd like for you to grab your phone and unlock it if necessary. And make sure, let's see, find your camera icon and click on that. And make sure that your front view camera is on. If it's not on, you can simply click the little circle with the arrows in it, and you should be able to see yourself in the front view camera, or sorry, in the selfie view camera. So you want to make sure that you sort of check your hair, make sure you're comfortable in a comfortable place to take the photo. Check your glasses, make sure that those are on straight. Get yourself ready, get yourself aligned. And if you're having trouble reaching the button to take the photo, which is in the center here, there's a little trick to taking a photo that works on most phones, and that is to press the down volume button on the side of your phone. For me, it's on this side. So if I'm taking a photo with my left hand, I can reach it with my thumb. If I'm taking it with my right hand, I can reach that down button with my index finger. So that's a little trick if you're having trouble holding your phone and if it's slipping for you. So you want to make sure that you are looking good and that your sign is in view, and that you have a good angle. And you want to check your distance. You want to make sure that you can get both your face and the sign in your photo all together. And then you want to take your photos. So press the button. If you flinch or if your full sign isn't in view, you can simply try again and take another, take as many as you need. And now you have a stellar Protect Medicare photo to share. So the next step is to email your photo to Laurie at PNHP.org. And we'll drop Laurie's email address into the chat for you now too. And you will see a poll popping up in a couple of seconds on your screen. And we would love for you to complete that poll and tell us when will you be emailing your photo to Laurie at PNHP.org. And we'll take just a moment for you to fill out that poll now. So while you fill that out, in case you have never emailed a photo from your phone before, you can simply go to your photos icon, which says photos, select that, and click on the photo that you just took. Or if you took a few photos, select your favorite of those of the bunch. And then you want to select the share icon, which is a little square with an up arrow in it. For me, it's on the bottom left-hand side. You want to click that and then scroll over to find your email icon, which for me, I have to scroll over a little bit to find that. It's on this menu here. Maybe you can't see that. It's on this menu here. So you want to scroll over and select your email icon, and it brings up an email essentially for you right away. So then you can just enter in Laurie's name and email address. So Laurie at PNHP in the to field up at the top there, and hit send, and you're done. It's in the mail. Fantastic. So we're sharing the results of the poll now. When will you send your petition? It looks like the biggest winner is this weekend. It looks like a lot of you will be able to find the time to print this out and share it with us this weekend. The second runner-up is early next week. So really thrilled that you all will be taking action with us in creating a photo petition this week. Okay, so on to the second way that we invite you to take action tonight. Hopefully everyone joining us on the call has already signed the petition that we've shared at protectmedicare.net. If you have not yet signed, please be sure to sign it tonight. Our team will be dropping the link to the petition in the chat for you now. But simply signing the petition is not our only ask. It's clear that we need a mass movement of people in this fight. And so our second call to action for you this evening is to write down the names of 5 people that you will talk to and ask them to sign this petition. I really encourage you to think about all of the people within your circle of friends, your coworkers, family, faith groups, political clubs, book clubs, recreational clubs, community groups, anywhere that you gather together locally, or any connections that you might have to friends and family across the country that you can reach out to. This is really an issue that touches everyone's lives, and people are most likely to engage when information comes from someone that they know and trust. So we encourage you to make that list of 5 names and give them a call and send them an email or a text and ask them to join you in signing this petition to protect Medicare. Thank you all so much for taking action with us tonight, and I'll turn it back over to Dr. Rogers now. Thank you.
Thank you so much, Morgan. And I do encourage everyone to take the photo. And, you know, one of the good things about with a camera is you can take 100 photos if you need to before you get just the right one that looks the way you want it to look. So everybody should be able to send great photos in and to get our movement with more momentum and get our message out there. So I want to thank everyone for joining our webinar today. And this is really our moment, you know, to try to move forward and trying to get the PNH chapters together and members all across the country to remove the bad actors and end the REACH program. So as Morgan said, you know, take action with PNHP and send your photo petition to Lori and share the petition. And you can share the petition with anyone. They do not have to be just in healthcare or whatever, because we all need healthcare at some point. Maybe not today, maybe not tomorrow, but eventually we will. So this is a program that will have impact on everyone. And I think we need to keep that in mind so that we understand the importance of getting rid of this. Like we've said, the webinar will be available next week and on the Protect Medicare website. I would like to also just thank our speakers tonight, who I think helped, you know, create this phenomenal program. Dr. Weisbart, who has done multiple talks on ACO REACH, and he still comes up with new creative ways to share this information. So thank you. And Diljeet, Diljeet Singh, who is, I have never seen her as a patient, but I can imagine she is just a passionate, caring doctor. I know she is. And thank you for sharing your story. And clearly you were affected by her story. And I think the way you told her story to everyone here, we were all affected too. And Morgan, thanks for joining us from New York and helping us get motivated to get our pictures done and share and get the movement rolling. So don't forget to send your photo to Lori@pnhp.org. I thank everyone for joining us on the call tonight. Go to our website and learn more and more about Medicare Advantage and the ACO REACH program, which is definitely something that we have to get rid of. So thank you everyone for joining us. Enjoy tomorrow and have a good weekend. Stay healthy too.